Thank you, Dr. Jayesh sir. That was very, very informative. Uh, it'll be in fitness of thing that I mentioned that the moderator of the session was supposed to be Dr. Nata Matambe, who unfortunately has not been able to make it. And I'm really the 12th man. So I've been pitchforked into the playing 11. So you'll have to bear with me. Uh, I'd just like to start by mentioning one point, and the point is regarding accreditation. You mentioned that there are 18 or 19, there are about now 20 hospitals in India which have JCHO accreditation, which we call it JCI because that's the international wing for JCI. But there was a time when JCI accreditation or accreditation from Canada or UK, that's a Trent accreditation, etc., were necessary in India. No longer. The reason is that India had its own national accreditation board. Now, the next step was that is that national accreditation board equal in standards to, let's say, JCHO or Trent or German or Canadian accreditation? The answer now is yes. Because in 2013, ISQA, which is the International Society for Quality Accreditation, which accredits the accreditors, has given NABH equal status to all other accreditations in the world. So we are now internationally recognized as equivalent. So all those hospitals which now have NABH accreditation don't really need any other foreign accreditation because now ISQA recognizes them as equal. There are only 14 countries which are recognized for their accreditation, and there are only 53 standards in the world which are recognized for accreditation by ISQA, and India is one of them. So this was just for information. Now you mentioned about the global medical tourism business growing. It's currently estimated to be about 24 to 40 billion. And it's going to go up, as you mentioned, the CAGR is expected to be about 20 to 30% annually. And it's going to happen because the healthcare costs are going to increase because medical technology is coming more and more into play. Age is a major factor. Everyone knows that you spend 75% of your insurance actually in the last 1 year of your age. And because of the technological advances not being available in certain countries or qualified doctors not being available, movement towards those countries will happen. In Asia, of course, India is one of the topmost countries which attracts medical tourism. The number one spot currently is with Singapore, but South Korea, Taiwan, and Thailand now are emerging, and Malaysia are emerging as major threats to India's suzerainty. Singapore is currently, as I said, number one, but Thailand recently announced that in 3 years' time, it is their national goal to become the number one medical tourism country in the world. That's their national goal, and it's 3 years. This is the government's directive. In India, of course, the majority of tourists come from SAARC countries. Some come from African and Middle Eastern countries. Particularly these days, as a clinician, I can say that we are seeing a lot of patients coming from Iraq and Nigeria. Most of them come for procedures which are cardiac, neuro, cancer, transplants, cosmetic surgery, dental work, eye care, orthopedics like total knee or total hip replacements, IVF, and even surrogacy. Because surrogacy is something which has a lot of problems in the Western world, but in India, we are far more liberal about it. And Ahmedabad, actually, from where, which is your next door neighbor, you come from Baroda, and Ahmedabad has probably the best developed surrogacy center in the world. The other important thing is I personally feel that there are 10 reasons why medical tourism works in India. And there are 5 reasons why we have problems. The first reason is what Dr. Jayesh also referred to, that is the low cost. That's the medical value part of the medical value travel. The second is availability of latest technologies. If you have a technology today in the United States or in the UK or Germany, you can be rest assured that it will be here in less than a year's time. The third is English speaking. Now that's a major, major impact. That's where countries like South Korea and Taiwan suffer as opposed to India. So that's number three. Number four is an increasing compliance with international quality standards and accreditation. Because after 2006, when the National Accreditation Board for Hospitals was set up in India, we really come up in a very, very short time in a big way. The fifth is availability of translators. So if you're looking for translation from English to Arabic or Arabic to Hindi or whatever, they are available. The sixth is little or no waiting. Now you all know that in Canada, the average wait for a hip replacement is 26 weeks. For cataract surgery is 16 weeks. Here, you'll get it done in a day. So that's the sixth reason. The seventh is that certain countries have visa on arrival scheme, which has been introduced by India. So if you have a passport, let's say an American passport, you can get a visa on arrival. The eighth is the medical visa availability. So there is such a thing called medical visa, which you can avail of, and you can come to India on that. The ninth is that more and more centers in India are getting direct connections by air. So earlier it used to be only Mumbai, Chennai, Delhi, and now you can get connections, international connections from virtually every part of the globe to even cities like Kochi, Calicut, Hyderabad, Ahmedabad, and you name it, virtually everywhere. And the last reason is, and I think that's a major reason, is the availability of alternate systems of healthcare. What we call Ayush. Ayush actually stands for Ayurveda, Yoga, Unani, Siddha, and homeopathy. So the availability of these systems is an important criterion. 26% of all medical tourists actually came from Germany. And out of those 26%, almost 90% came for the alternate systems of medicine. Switzerland is the other country which attracts a large number of medical value travel, despite being the most expensive. But they come there because A, they offer a lot of shopping opportunities and a lot of locales which are great to look at. But more importantly, they still have the old system of spa and other systems. You know, tuberculosis at one time was treated in sanatoria, and people who were rich from India would go to Switzerland through the sanatoria. So these are the reasons why travel, as Dr. Jayesh Shah mentioned, increased, so that last year we had more than 1 crore visiting India for treatment. In India, within India, 45% of all medical tourists actually go to Chennai. That's a huge number, but that's the reality. The other reality, let's face it, and we thank you from the core of our heart, Dr. Jayesh Shah, and all of you who've come from United States for the offer to help. But realistically, it'll be somewhat difficult to imagine a large number of medical tourists coming to India from the United States. The reason for that is, as McKinsey studies and studies by Deloitte have pointed out, that distance is a very major factor. Because many of these people will develop complications if there is a long journey back or to the destination. Now, United States and India almost have minimum of 16 hours of flying time. And that makes it very difficult to expect a large exodus coming India's way. And the second reason that must be mentioned here is that the system of medicine that is practiced in the United States is very litigious in nature. And that is going to be a major problem, and has proved to be a major problem. As and when we have gone with delegations to the United States to talk about medical value travel and the opportunities India offers, we're always confronted with this situation that if something goes wrong, where will the doctor and the hospital be sued? In India or in the United States?
Not if, but where? Right.
So that's the other thing. Now, Deloitte study in 2008 predicted that medical tourism originating in USA would jump 10 times by 2018. But the total number that goes out of United States is about 60,000. And most of it goes for plastic surgery, dental surgery, which is not covered by insurance, and it goes to countries which are nearby, to Cuba, for example, to Mexico, to Bolivia, and countries like Brazil, which offer a lot of plastics and reconstructive surgery at low costs. So realistically, it will be difficult to imagine that too much will come from the United States. But let us be realistic and say that the value of medical value travel in this country is going to increase. So whilst we may not get too much from the United States, but we are likely to get a huge number from neighboring countries, and we are likely to get a large number from countries who do not have the technology, from Africa, which is the part of the continent which does not have good health care. Nigeria is an oil-rich country, but it has very poor medical infrastructure. And as I mentioned, as a clinician, even today I saw one Nigerian and one patient from Iraq in the morning in my outpatient department. So this is the area where you need to focus your energies on if India is to increase its medical value travel. But there is a lot that we can learn from United States, and we can take help from API in providing the kind of services and the improvement in quality that is bound to come from India. Let us also not forget, America spends 18% of its GDP on healthcare. India spends 1%. And America is a rich country which is still struggling, despite spending 18% of its GDP, to provide healthcare to the masses. So perhaps there is an opportunity for the two countries to benefit from each other, because the low cost of India can probably benefit a large number of masses in USA. So if it's a two-way street, I think both countries will benefit. May I now ask?
Can I just build on what you just
We'll
said?
come to that, but
No, just on what you just said.
Yes.
You had said there were 5 points. Could you tell the other 3 negatives?
No, I'm going to talk about the negatives in the end, because I'd like to be positive, at least to begin with. Because first of all, I'm going to ask my friend Mr. C.K. Mishra, who's the additional secretary in the Ministry of Health, to talk about his views on healthcare in India, and particularly the medical value travel. There are a few questions which had been circulated by the organizers, and there are at least 2 which I felt that I'm going to request him to definitely include in his address. One is, what are the schemes and incentives being offered by government to promote investments in the healthcare and medical value travel segment, if any? And how have public expectations changed vis-a-vis delivery of healthcare services? Is there enough demand for quality healthcare services, or is the chunk of the demand for basic healthcare? Please include these in your address, sir. Thank you.
Thank you, Dr. Puri. I'm conscious of the fact that the composition of this room, the people we have, it's not one of those routine things where you talk about healthcare delivery system in a country and get away with. I'm also conscious of the fact that many a times, when much of it is about private investment, government is there for form rather than content. But let me begin with saying that even though recent activities in India and around the globe have seen a lot of private investment coming up in some sectors of healthcare delivery, the primary responsibility, at least in India, still lies with the government. And one of the major responsibilities when it comes to things like investment in the healthcare system by private sector, or if it comes to medical tourism as such, is the government's role as a policy enunciator to create an ecosystem which facilitates such things. That is the single unifying umbrella and the role that government would really like to play. Uh, when we talk about getting people into the country from the medical tourism point of view, let me upfront state that most of this is happening in the private sector. Therefore, one corollary and a necessity really is that we need to attract in India enough investment from the private sector in at least the tertiary healthcare scenario in order to be able to attract more and more people from other parts of the globe to come into India for medical treatment. It's one question that Dr. Puri raised was, do we have enough? No, we don't. And when there is this gap between demand and supply, investment should naturally have come in. But let me confess that even though we've seen a growth of private investment in healthcare systems in India, it's not yet enough. There are many roadblocks and many things need to be done. And we learn from the experience of everybody here and what really government needs to do and what the investor needs to do. But the fact remains that seeing this gap, the expectation is that more and more people will come in. I've been tasked by Dr. Puri also to give you a flavor of the Indian healthcare system at present. So let me spend a minute or two on that. As far as the government is concerned, the question before the government is, how do you reach to the people in the remote areas, given the population, the geographical condition, and the diversity of the country? The initial question was actually access rather than quality. Therefore, some 8 years back, we had an ambitious scheme called the National Rural Health Mission launched, where we were only attempting to reach everyone for the basic medical facilities that are required. As on date, we feel that job is well done. We've really fanned out and reached out to different parts of the country. So therefore, now the government focus has necessarily to turn on to quality. Because there is a demand, the issue of basic healthcare versus quality healthcare. There will always be a segment which will be happy with basic healthcare. But there is a growing segment of Indian population which would rather have quality healthcare. And it is for the government and the private sector to play this game together well to get to that level where we can actually provide quality health service. Please remember that even with 1% of the GDP being spent towards health, we are not merely lowering the cost of medical treatment for the poor and the far-flung people, or not even, or not merely reducing the out-of-pocket expense for them. We are actually, under the government system, providing services free completely, whether it is treatment, whether it is diagnostic, whatever, or drugs. It's not an easy task, but it has to be done. And one of the reasons why the government must do it is the fact that while there has been investment in the tertiary care sector, there has been no investment in the primary healthcare in the remote areas of this country from the private sector. Recognizing the fact that the conditions may not be as good or ripe today for the private sector to go to the rural areas, the expectation now is we'll take care of that mass, you take care of the quality and investment in the tertiary sector. So that is a point I just wanted to make. Now, even in the tertiary care sector, if you look at medical value tourism in India, it is limited to geographical pockets. Access, maybe travel access could be one of the reasons. But the growth has only been in certain major cities of the country, not even uniformly across cities in the country. And that may, on one hand, be a good thing because you are doing it in a concentrated way in few cities. On the other hand, it's a bad thing for the country because the other areas are not only able not to provide medical facilities, but not even attract people from outside. So we need to really work on this, how we talk about different partnerships with the private sector. PPP in health sector, let me confess, is not yet robust. But it's not as if PPP is absent in healthcare. It runs in various forms. If you look at the primary healthcare system, in majority of the states in this country, the diagnostics and other expensive pathology, etc., is all outsourced. So there is an involvement. But when I say we don't have a robust PPP model, I say so because we have not seen too many successful experiments in this model in this country. The best PPP model that we have today is of provision of land and infrastructure being provided by the private player, which I personally feel is not enough and not the best. Ultimately, where is the country looking at? We are actually looking at the primary goal being universal health coverage. There are 4 issues that we should really be looking at. 1, access. The second is affordability. The third is sustainability. And the fourth is quality. If we can cover these, if we can reach everyone, provide a treatment at an affordable cost with the minimum out-of-pocket expense, and we build a model of affordability which is sustainable. See, government interventions will not be perpetual. Therefore, we have to build a model which can live on its own. You can't do a treatment for 5 years and leave the patient for the next 5 years to be on his own. So a model has to be sustainable. And as I said in the beginning, once we have this model going and in place, what we really need to think about is how do we convert it into a quality healthcare for the people? Definitions of quality vary country-wise. It varies according to the need of the population, and it varies according to the need of the caregiver and the care receiver. But the fact remains that people are entitled to the basic minimum quality, and that is the objective. Now let us look at medical treatment. We are not talking about basic medical treatment as far as medical tourism is concerned. We are concerned only with super specialties, in fact. Nobody comes to you for anything less than that. And if you see medical tourism broadly, we say anybody who comes to India for medical treatment is a medical tourist. And this has increased largely due to extreme level, very high end participation of the private sector. And we've been able to develop a high value health service that are comparable to the best in the world today. And that is why we are getting people. The reason being quality, delivery, and of course, affordability. So we have even let me confess that the numbers are not such that we really need to be trumpeting around. But India is certainly seen now as a destination, if not the only destination. And the purpose of a joint mechanism between government and private sector should be to actually take it to a level. I really can't say like Thailand that we'll do it in 3 years. But at some point of time in near future, reach a point where people say that it's not the only destination, but one of the best destinations. That should be really the goal to move for. Now, if you look at the present medical tourism scenario in this country, government policies per se for medical tourism, quote unquote, may not exist. It's an amalgam of policies between different departments which actually help facilitate this. As I said in the beginning, it's about creating an ecosystem. If you have a medical visa specifically designed for a country, that is a policy initiative which gets people in. If the tourism ministry is doing a lot of homework on advertising India as a medical hub, that is one government policy which is helping you. And government policies may not be in terms of treatment protocols in hospitals that are well established and private sector is taking care of. What we need really to do is, through various departments' efforts, we need to create an enabling environment where we get the people here. Now, what does this entail really? If you look at it, it's contacting patients in the first place, they contacting us along with that, their choice of hospitals, the expenditure, and the medical visas. If we put all these things together, we have a patient in our country. Then what we need to do is really to ensure that we make his life comfortable in this country, so that when he goes back, there are 4 more who talk to him and come to you. But this requires a lot of stakeholder coordination. I mean, there are many players in this. In fact, government also has many players within government to help this. Private sector similarly has many players. It is the management of a hospital, it is the location of a hospital, it is the specialization in a hospital. All this put together actually will do this framework where we can get people. So we have to actually establish very strong linkages and move ahead from where we are. If you look at the total figures today from the foreign tourist arrival data, I think it's around 2.5 to 3% that come for medical tourism. Not a very high figure. It appears high because the servicing centers in India are not too many. And what are the places from where we're getting most of these patients? Afghanistan, Bangladesh, Gulf countries. A, as it was mentioned earlier, it's proximity. B, there's a fair amount of affinity. There's a fair amount of cultural affinity which tells them to come. I mean, the question was raised, why are people from US not coming here and going to Singapore? The reason is that recognition of being one is a little farther remote than maybe with Gulf or Bangladesh or Afghanistan. So, but it doesn't really matter to a country which region is actually overriding and coming in more numbers. Where it actually matters is that if we, let's say, for example, did have far too many people from the USA coming to India for medical tourism, would that have added more to the economy of the country? Because when you come for medical tourism, it's not treatment only. There are certain spin-off benefits that the overall economy in the country gets. And one should also be looking at that. So it is to attract that segment that we need to really strengthen our systems. One of the issues which has been raised perpetually is accreditation. Dr. Puri explained the entire process, and he said NABH is there to stay, recognized, and final. Now what Dr. Puri and his team need to really do along with government is to convince these countries that it is NABH and NABH is worth it. See, there is still this suspicion in many of these countries in the West that NABH may not mean the same. There's a lot of convincing to be done to make people believe that this must happen. Therefore, one of the attempts that we need to really make is to get high-value tourism. And high-value tourism will not only mean greater name and branding India, as Dr. Jayesh Shah was saying, but also will mean add to the economy of the country and perhaps a huge amount of professional. There are many issues in the Indian medical system, let us understand that. These private hospitals need super specialists. In this country, I mean, we are in an open discussion. Let me confess that we have about 56,000 MBBS students passing in this country from both private and medical colleges every year. Out of them, only 22,000 go on to become do a PG. Therefore, we have only 22,000 super specialists in the country. These are issues which we need to attend to. If we want to increase medical tourism in this country, we need to have more super specialists. There's a constant tug of war of super specialists between the private sector and the government. I mean, one of the famous stories that is often cited everywhere is that a super specialist would jump from the government hospital to the private hospital, and an allied health worker and a nurse would jump from the private sector to government sector. So these, and the shortages are across the board. But then there are some states in India which have made a head start. You mentioned Chennai and Tamil Nadu. I wonder if you're aware that Tamil Nadu has a dedicated medical tourism desk in their tourist centers. They've worked on it. And that is a model we should all follow. So we need to make our systems more acceptable. When I say acceptable, that we have to be recognized by the others. Ours being very good doesn't really help. The other person must agree with us. So if we are able to put all these things together, the national policies, even if they don't specifically spell out these things, are not going to be an obstruction at any point of time. They are supportive, and the health ministry in particular would be very happy if the private sector and the government sector could work together and create an atmosphere where we get more and more people for medical tourism. Please understand that with the limited resources, there is a pressure on everyone for the domestic patients also. As I mentioned, super specialization being such a scarce thing, we need to also take care of our population. And with the recent studies on non-communicable diseases that have come out, I dare say that we need to get more and more specialists in place and hospitals in place to treat patients with cancer and CVD. I mean, the growth is such that many people are calling us the capital of diabetes and hypertension. So lifestyle diseases, which we thought will not affect us, have suddenly taken over. In fact, the total mortality in this country, it's more than 50% from non-communicable diseases and less from the communicable diseases, which was the story about 10 years earlier. So we need these institutions for us also. And more and more institutions come up, it will open a gateway to the world as well. So I think these are some of the things, but the basic thing today, we have experts who have come from outside, have their views. And I, as a government representative, let me sincerely, assure you that I am here to listen, to absorb, according to my capacity, of course, and carry back some learnings from this session, which we could then dovetail into our policy planning and make things look better. Thank you.
Thank you, Mr. Mishra. I think this very one sentence summarizes everything, and that is the commitment on behalf of the government by Mr. Mishra that private and the governments is not really, there shouldn't be any difference. We are all here to provide healthcare. The question really is whether we are here to provide healthcare to medical tourists, or are we here first to provide healthcare to India and to Indians? But it's important that when medical value tourism happens, it really increases the sheen on the value of treatment that the country is offering. And it'll be not surprising, although he is right when he said that majority of the people come to private institutions. But if you were to go in Delhi to just two institutions, All India Institute and GB Pant Hospital, you will see that a large number of people from neighboring countries are there, from Nepal, from Pakistan, Pakistan particularly for congenital heart diseases and transplants because they are not available in Pakistan. And that's not really a very friendly country, but yet we offer them treatment at the same rates that we offer to Indians, because usually they can't afford. In fact, many associations actually raise money to treat them. So what is happening in India is that medical value tourism is increasing. The value of healthcare that is being provided is increasing. There is increasing quality demand and increasing quality understanding that ultimately, quality, as he rightly pointed out, it's like beauty. How do you define quality? It lies in the eyes of the beholder kind of situation. But in medical quality, it's very clear. Quality is really outcomes. If you are a patient, you want that the treatment should result in good outcomes. And if you are able to provide them without causing collateral damage, like hospital-acquired infections, etc., etc., then that's good quality healthcare. Anyway, we now come to a take which is completely different, and that comes from my colleague, my friend, Mr. Abe Soi, who has recently introduced a dose, shall I say, a massive dose, an injection of funding into a otherwise somewhat comatose hospital, and it's now thriving. He's someone who has been in the PE fund space, and he's been in the financial space for a very long time in Southeast Asia. So he has the experience. And having now invested and brought up an institution which, as Mr. Prasad introduced in the introduction to Mr. Soi, which is really flourishing now and is likely to become a 1,500 bed institution, which is massive. Let's hear from him, particularly about the investment scenario and how medical value travel can be dovetailed into the investment part of it. What is the situation of PE funding for healthcare, and why is it, Abe, that last year we saw a dip as opposed to 2 years earlier? Over to you.
Thank you, Dr. Puri. So I'm going to probably provide outside-in perspective to medical value tourism, and what that means from investment climate or investment proposition from a healthcare delivery model, i.e., the hospitals. So I can tell you from a capital raising or investment standpoint, when propositions come to us, one of the most compelling propositions, one of the most attractive part of the proposition of a hospital or a healthcare delivery model, especially in not so much in tier 2, tier 3 cities, but especially in tier 1, be it the NCR or Mumbai, which are destinations for medical value tourism, or Ahmedabad also, so to say, is medical value tourism. When we talk about attracting medical value tourists, I think it is for us something to repel rather than attract. I think by automation we should be attracting. Just the sheer numbers are absolutely compelling. If you just look at the cost advantage we have in terms of value tourism, in the US, the cost of a bypass is $100,000, I believe. In the UK, it's about $70,000. In Singapore, it's about 17,000. I think the Bumipram Hospital in Thailand is doing it at about $11,000. We can do it over here in the best of hospitals at anything from $3,000 to $4,000, I believe, comfortably. So, I mean, that is the level of disparity. That is the level of the difference that we have. Bone marrow transplant, we talk about how high-end, high-value diseases. In the US, it costs a package typically is $300,000. In India, we do it at $30,000. Now you got, the world, the way I look at it, is divided into two parts. The have and the have-nots. The US and perhaps some developing countries which are covered by insurance. But even in those countries, you have cosmetic, you have IVF, you have surrogacy, you have dental, you have some amount of hip replacements which are not covered by FDA, etc. over there, which, you have some amount of vacuum in India, and we do have a trickle-down effect. In Chennai, I believe, some time back, I was reading about a story where a hospital was serving a large number of patients from the US alone in hip replacement. Other than that, if you look at where is the Middle Eastern cluster, the SAARC countries, the Nigerian countries, whether it's Congo or Nigeria or the CIS countries, I think, there are, again, compelling reasons, absolutely. The people at the margin of society, they don't have a choice. If you go to a place like Nepal, Kathmandu has 2 cath labs. They don't have a single linear accelerator for, let's say, oncology. Afghanistan, similar situations. So across, we talk about transplant. I don't think, Pakistan, for example, has a liver transplant or a kidney transplant practice, so to say. I mean, what is the choice that people have? Some time back, there was a story from a hospital which came where was this lady, she sold a piece of land, brought her son, came down from Congo, sold a piece of land, was a villager over there, came down, and he was expecting our son to be in hospital for 8 days, landed up in being in hospital 15 days. So she goes back, sells another piece of land and comes back. So, I mean, this is necessity. This is absolute necessity. People are coming to India not because they want to, or I believe that Indianness is in vogue. I think they are coming to India because they have to. They don't have a choice. People don't travel for medical purposes out of choice. You don't go to a country, I mean, you probably go to America or somewhere else, but you don't come to India out of choice, or probably don't even go to Thailand out of choice. You go there because the cost, you don't have, I mean, you have resources just to go to in India, to a place like India, and get yourself fixed over there. So, if I look at the trends over the last few years, I think over the last 5 years, most of the major healthcare players, from 5 to 10% of their revenues coming from medical value tourism. Now it is about 25 to 30%. In terms of RPOBs, in terms of just sheer profitability out of these numbers, typically people charge about 50% to 70% more to international patients than they do, at least from a private sector perspective, than they do to domestic patients. So you are looking at RPOBs of about 50 or 60,000 rupees, whereas a cash paying patient in India gives you an RPOB over 24 to 27,000 rupees. Effectively, what does it do? From a hospital standpoint, you still have ESI, you still have CGHS, you still have ECHS, which are not very highly remunerative from a private sector standpoint. But when you mix it up, when you mix it up with international or medical value tourists, which are at a higher RPOB, you're able to subsidize and so on, move further in your business trade. So I think clearly we need to step up in terms of addressing this marketplace. Once we are able to step up, I mean, obviously your investment climate changes, your investment proposition becomes even more attractive, and that compels private investors to put in money. That is coming to attractiveness. That is so far as attractiveness of investment in the medical or in hospitals via the medical value tourism part of this thing. But I think, when you come to speaking about Ps, I think Dr. Puri asked a question why the number of investments have. I think a lot of that is to do with the investment climate and the uncertainties in India. We have seen, from a tax standpoint, from a regulatory standpoint, a lot of investments have been opened up. I think there's a lot of scrutiny in terms of structures. Most of these private equity funds are based overseas, and these are inbound investment from an FDI standpoint. But I think, over the last few years, there has been clamping up, I think, and an extreme amount of scrutiny in terms of structures, in terms of inbound investment, so on and so forth, which has created some amount of issues as far as the India investment story is concerned. I think, 3 or 4 years back, in a larger sense, India was the darling of international Ps, but right now is not necessarily a good buzzword. So I hope that answers.
Thank you, Abhay. Just in case you were wondering what he means by RPOB, he was referring to it repeatedly. RPOB is average revenue per occupied bed. So that's a term that we in management use when we're talking hospital management. So an empty bed doesn't give you a revenue. So it's RPOB that's what he was referring to. For the final word, who else but Dr. Nandini Tandon? Overqualified, I think, for the job. PhD, works with Stanford, with so many organizations, has been involved with PhD from Duke, by the way, Ivy League institution, and she's based out of San Francisco. She's not a doctor from the medical part, but she's the real doctor because she's the PhD doctor. So Nandini brings to us a perspective which is a kind of an admixture between her Indianness, which brings her repeatedly here, and her work, which is based out of United States. And she brings a perspective not just from the point of view of a medical person or from an administrative person, but also from the point of view of people who do startups, who are in medical technology, and who work with the medical sector in investments as well. Nandini.
Thank you, Dr. Puri. What a very gracious introduction. No doubt we keep coming back to India, besides the very strong sentimental ties we have. here. I'm sure each one of us would have enjoyed meeting Dr. Natsa Menabde, but as you said, you were the 12th man. We are the ones who got the sixer out of this whole thing, that we have you as a moderator, and thank you for that. I want to really appreciate the opportunity provided by FICCI. It's such an honor to be here. I'm learning a lot. Uh, Before I delve into my thoughts and my experience, I wanted to introduce two people that I'd like for them to stand up. One is Mr. Senthi Cherry. He is part of the Pravasi Bharati delegate who has come from United States, and he's a huge connector and somebody who brings a lot of synergy to the medical industry, and we're grateful to you for that. And the other person is my partner in crime, my sister, and that's very Indian. It's Priya Tandon, and she has also come from the Bay Area, and I acknowledge their being here also. I want to introduce you. So from my perspective, being an Indian who has recently broken the glass ceiling, because in the 65-year history of the Silicon Valley Hospital, El Camino, we never had an Asian who was on the board. And being the first Asian, and I hope this is not being taped, because we always have this, I would say, healthy competition in Silicon Valley between Indian and Chinese. The Indians were thrilled that the first Asian on the board was an Indian, and soon after that we had a Chinese also. But in any case, and now the vice chairman of the board, I really think that there is huge opportunity in the challenges that have been exceptionally articulated by all the panelists and by our chair, Dr. Puri, where India and United States can come together and look at quid pro quo and look at where we can have our strengths amalgamated and our weaknesses mitigated. In both India and USA are going through a churning right now. Speaking for United States, that I'm much better qualified to speak. As you know, Obamacare has created a situation where we have to look at where healthcare industry is, and it's not everywhere. Everybody has adopted Obamacare, and there's a huge question mark as to how it's going to be. Irrespective of the question marks that we have, the one thing that is for sure is that we don't know what the visibility is going to be on the horizon 5 years from now. And as President Kennedy had said, anytime you have challenges, you have huge opportunities. And I think it's in that uncertainty that we have in America right now, where we are not quite sure how the quality care is going to be sustainable and affordable. That's where I think in the equation, the medical tourism coming from India can be a huge solution, a part of the equation of the solution that we have. In the list that you very well articulated, Dr. Puri, where you said the 10 reasons why India is a very good destination, if I may add two more. One is, I think India is one of the few places in the world where we see an entire spectrum of diseases. So many things that we don't see in other parts of the world, we see out here, just given the fact that we are a subcontinent. And the depth of knowledge that the physicians bring out here, I mean, the economy of scale and the largeness of patient movement is so large that there's a large degree of confidence that when a patient comes here, the physician will be able to literally have the finger on the pulse. The second thing that makes US for the American citizens to come back here, irrespective whether they're Indian origin or not, is the whole brand India. This is the positive part of brand India, is that we see the hospitality of India. As we all know, you can go to Switzerland, but India brings a warmth and a caring, and the quality of nurses, above and beyond the exceptional quality of physicians, the quality of nurses out here. And post-operation, all the post-op care, besides the physician's contribution, comes from nurses. And I think that is also something which is huge out here. The downside that we see is, just as Mr. Abhay was sharing earlier, of course, there's the uncertainty aspect. I think the whole political uncertainty, the financial uncertainty, the infrastructure issues, but also when we hear in media things like the negligence that sometimes comes, and maybe media takes it out of proportion given the large number of patient population out here, but those aspects don't help. But where is it that US and India can meet? What can US bring to the table? What US can bring to the table for sure is that we are at a much more mature, evolved state as to what has and has not worked. And we do have a very strong model of both private and public participation. So the government has taken a very active role, and there's a huge private sector also. And irrespective of how much money has gone into it, we are standing at a crossroad where the system is broken. And we might not know which direction we will go forward, but we certainly do know that the status quo cannot be business as usual. So America can offer a huge case study as to what has worked and has not worked. So that's one thing. The second thing that America can offer is, as we were talking earlier, and I think Mr. Mishra was also saying that the specialty, there are only 22,000 specialty competence that is available in the professionals. So given that was the case, America is the #1 destination for specialties. So that's the second area that we can have. The third area is, as you know, we take great pride that the quality of education and the quality of research, I think no other country on planet Earth can boast of the research focus that we have. And as we are going forward, before India did not have the lifestyle diseases, now they do. Absolutely, we look at India as the capital for diabetes, for cardiovascular, and the list goes on. Research as to how we can have large gene pool research done in a very systematic, thoughtful manner. I mean, what could be more stronger in preventive medicine than having an appreciation of what kind of genetic proclivity we have and how we can address them at a very early stage. So while we are looking at people of different ages and we are looking at the different modalities that can be brought to bear, I think research can be an exceptionally powerful area. And as you know, translational research is huge in my alma mater, Duke, and at Stanford that I live up the road from. So I think translational research can be huge to be bear. And that is where we can partner with India. The other place where United States can be a very strong ally in our partnership is especially Silicon Valley. We're very proud, being an entrepreneur myself, being a venture capitalist for the last 12 years, and my last fund was 1.2 billion. Having sold innovation in biotech, medtech to Pfizer, Amgen, GE. I mean, out of the 14 investments I made, I have sold 10 companies and taken 2 public. So we have a very strong track record. So we look at whom we can sell to before we invest. So from an entrepreneurial and innovation standpoint, there is no other place like Silicon Valley. And any partnership that we can do there, where we can inject both innovation and entrepreneurial culture, also in the medical tourism, that is going to definitely allow us to have more ROI for any investments that we make. And finally, looking at from where the United States can also bring is governance. We take great pride in the governance issues. And being on the board of El Camino Hospital, I can tell you that a lot of time is gone into what is it that we can ensure that the running of the hospital can take place in a manner where a 360 degrees is taken care of. So those are the aspects that we can bring from the United States at large. From an El Camino Hospital that I'm the vice chair of, there are a few things that I'd like to highlight because it can be a case study. Very recently, in the first week of December, the mayor of San Francisco, who is Chinese American and had been to China many times and never to India, we were fortunate to have a very strong delegation come from San Francisco to India. And Priya was leading the national briefing of the mayor, and I was leading the healthcare. And what we So we have already begun the process where we're looking to see what is it that we can do between San Francisco, California at large, US, and obviously India. And one of the things that we were fortunate is that El Camino Hospital is an affiliation with both Stanford and Palo Alto Medical Foundation because of the proximity, because of the physicians who come to El Camino. And El Camino and Palo Alto Medical Foundation has 1,400 physicians. Stanford has several hundred, as we all know. So it's a large consortium of thinkers that we can lean on in looking at how this partnership can go further. Now, El Camino, we are very, very proud that we have one of the premier leaders in South Asian Heart's focus. And we all are very aware and concerned that the South Asians, Indians fall into that bucket, are prone to CAD, the coronary artery disease. And as we know, both men and women are afflicted. And this is something that, that early mortality. So we have in our hospital, we have an institution focused on that. And that is where we can, in the case of medical tourism, also look at where we can have quid pro quo. Secondly, we're very proud that we have a hospital dedicated to women, and which is really a leadership role. We all know that at the end of the day, it's the women who take care of the health at home. It's the women who take their fathers, their husbands, their brothers, their sons to the hospital. It's not usually the other way around. So for a woman to be engaged is really helpful. And I'll just take a minor deviation. I was on the board of a company called U Systems, the only woman and the only Indian. And U Systems' focus was looking at ultrasound imaging for breast cancer early detection. Now, this is very important because Indian women have breast tissue which are dense tissue, like the Asian women, whereas the Caucasian have fatty tissue. And X-rays that has been around for several decades cannot detect early cancer in dense tissue. We had to fight an uphill battle. This technology had come out of Silicon Valley, and we had invested in it. We had to fight an uphill battle with the X-ray lobbying. As you can imagine, they're very powerful. It was not easy. We went and spoke with the governor of California. We wanted to increase the awareness. He said yes, and next day it was vetoed. Following year, he did pass the bill, but it was huge lobbying that we had to go against. But we did succeed there. We also got, as you know, it's not easy to work with the FDA, who rightfully is very responsible in being very careful what they give approval to. And the Food and Drug Administration made history by unanimous 13-panel judges giving us a thumbs up on the approval. And not surprising, General Electric bought our company for all cash, no milestones. So it was an amazing outcome. It is going to definitely help save lives. This is another area where India and US can partner up because we can bring the latest breakthrough medical technology and biotech and medtech technology to India and work with you to reach the masses. I know that time is of the essence because we would all on the panel, and especially our chair who's leading it, would like for us to have an interactive discussion. So with that, I'd like to thank you for the opportunity, and I'm open to any questions. Thanks.
Thank you, Nandini, for the insight that you've given. One way that you can also help is not take our super specialists away to US.
No, I was trying to bring, that's true. We stand guilty.
I think open to questions. Yes, sir, and please identify yourself and to whom the question is.
I'm Pramod Agarwal, Conceptual Creation. My question is to C.K. Mishra. You have mentioned various measures from the government side, but moving around most part of the country during my journey, and I observe, as I belong to one of the city in UP, even the poor people does not want to go to government hospitals. And this is very, very serious. They put their jewelry in custody and go to private doctors, private hospitals. How can government can change this kind of attitude? In my childhood, I remember I have been treated by government hospitals. But if I remember today, maybe last 40 years, I haven't go to any government hospitals. But the workers, the lady who work at my home, I still remember. even they do not go to government hospital. My suggestion is, as you are from the government body, what you can do is, government can rebrand, removing the fear of the poor people or the middle class people, that they can restart going to government hospitals. And what way they can do is, my suggestion is,
May I ask you to discuss the suggestion at the tea break? What is your question, sir?
yeah,
So
my
that he
question
can
is
answer.
that, is the government of India is aware about it? What measures they are going to take? Is there any rebranding campaign you plan to launch? And what Nandini recently quoted is, even the cities, the woman dedicated hospital can be set up. And I would request Mr. Mishra that this measure also should be considered by the government, putting in various cities in the initial stage, total dedicated women hospitals, and a campaign of door-to-door through SMS that please do not fear, come to us, please go to government hospitals, take the facilities. Thank you.
Perception, correct. Facts, not so correct. See, the people, poor people in the rural areas, the biggest reason for indebtedness so far has been medical expense. Let's please understand that, because that is a necessity they can't avoid. Government facilities are available free of cost and are accessible. But the population today is, as I said, also looking for some amount of quality which is better than what is available there. Having said that, let me tell you that huge amount of investment into better infrastructure creation has taken place in this country. I'll give you just one example to answer your question. Institutional delivery in government hospitals has gone up about 20 times in the last 5 years. It is, yes, yes. See, assured quality, the measure of assured quality is the outcome. If you have your MMR going down, it shows that the institutional delivery system is working. I mean, how else do you measure health outcomes? If you have the IMR going down, that means people are being serviced. Having said that, let us also admit that we still haven't reached a stage where we can say that we will provide every service that you need. There's a lot to be done.
Mr. Mishra, general perception is that if they go to government hospital,
Can you wait for the discussion outside the tea? The next session has to begin. So we'll
Just give me 1 more minute.
I request Mr.
they
Agarwal
will
to
lose their
continue the
life if they
discussion.
go to government hospital.
No. I think today, with a problem in Delhi, AIIMS is as preferred as any private sector hospital, or perhaps more preferred. So let's not just bracket everything that is government together and say it's bad.
Most part of the country I am talking.
Excuse me, ladies and gentlemen, may I request that this session is
I think we
to
need
ask
to
a
know more
question
about
and
it.
to hear from our panelists what the answer is. If there is any discussion, you're free to do so. Tea break just outside. I think we don't have really time, sir. May I request you? Sorry, sir. I have been told by the organizers that there is no time, but I'm quite sure that each one of us who's on the panel will be available to you outside for any question and for any clarifications, and we'll seek your advice on any of the matters. After all, as Mr. Mishra said, that all of us, and he articulated it well, we are here to learn from each other. So if you have any suggestions to make, they are also equally welcome. But let's pay our obeisance to time. Thank you very much. May I, on behalf of all of you, thank the panelists, Mr. Abhay Soi, Mr. C.K. Mishra, and Dr. Nandini Tandon, and thank you very much for your attention.